So good evening, everyone. Thank you for making time to join us today in our 152nd Fireside chat. My name is Dr. Yuri Kokech. I'll be your moderator for tonight's session. And tonight we have quite an interesting topic on choice-restricted conservative kidney management with case-based insights. And our guest speaker for tonight is Professor Nicola Wearne, who's an associate professor, and she's the head of the division of nephrology and hypertension at the Groote Schuur Hospital and University of Cape Town, South Africa. She is currently the secretary of the South African Nephrology Society, a member of the African Nephrology Society Executive Committee. She is the chair of the Teaching and Education Committee, as well as president of Women in Nephrology Africa. She is head of both HIV kidney service and peritoneal dialysis service in the division. She is currently completing her PhD, which is related to HIV and kidney disease. She has published widely in this area, and Professor Nicola has a strong passion for kidney supportive and palliative care programs in South Africa and was involved in the production of guidelines on the topic for South Africa. She is actively involved with the International Society of Nephrology and is responsible for managing the fellowship program in the division. So tonight will be second kidney supportive care series, and over to you, Professor Nicola. Looking forward to an insightful discussion. Thank you.
Thank you very much, and thank you for the warm welcome. I'm really happy to be part of this great initiative. I have a very strong passion for conservative kidney management, and as you'll see, working in South Africa, we really do have we really do have to work with a choice-restricted conservative kidney management plan. So I'm going to take you through some lessons that I've learned, our guidelines, and a few cases to try to explain, how to manage these problems. So the rise in chronic kidney disease globally is of a particular concern for us who are working in low-resource settings. In many low and low middle income countries, particularly in Africa, including South Africa, there's either restricted or no option for kidney replacement therapy. And there's this tug of war between the fundamental premise of the human right to health and the resource constraints that hinder KRT for all. And priority setting is an essential component of providing health in these regions where resources are all constrained. So in South Africa, because we can't offer dialysis or chronic dialysis for all, we are able to offer acute dialysis to everybody. But chronic dialysis is restricted. So we have set up we've been forced to ration kidney replacement therapy and have created explicit rules to assist this process. And it's important for us to do this in a very organized way to ensure fairness and transparency. Only patients who are transplantable can be accepted onto many public sector dialysis programs. We do have strict rules. They do vary between units or between provinces. So I don't want to be explicit about them, but really the bottom line is that a patient needs to be transplantable. A patient requires to be medically and socially acceptable to undergo a transplant. Therefore, adherence to previous therapies is very important. In our facilities at Groote, where I practice, dialysis slots are always full, and a new patient can only be accommodated once an existing patient is transplanted or demises. We do have an active transplant service. We do what some people might think is a small amount of transplants a year, but we do between 50 and 60 transplants a year, and we try to turn our service over. So this lack of kidney replacement therapy for all who require it and the limited palliative care services have left many patients and their families unjustifiably suffering in the last days of their life. This is compounded by the moral injury experienced by medical teams where they feel abandonment for their patients who have been turned down for these programs. There's also an impact on the decision-making makers. I chair the session once a week, so I just go back. But having the actual selection criteria does give a sense of fairness and transparency for all. I want to emphasize the universal health coverage, but particularly on the last bit, which is one shouldn't, I'll go from the beginning, but the universal health coverage states that all people can use the promotive, preventive, curative, rehabilitative, and palliative health services they need of sufficient quality to be effective, while also ensuring that the use of these services does not result in financial hardship. This is very important when it comes to expensive forms of therapy like kidney replacement therapy, because I've seen families that have actually become bankrupt over trying to provide dialysis for their loved ones. So as many of you are aware, there has been a brilliant initiative from the ISN to help assist with what can be challenging area to work in. And I was on this committee, very fortunate to be part of and learned a lot from being part of these very educated people. But really my focus was on how to support conservative kidney management when one does not have a choice. So I'm going to take you through what I've learned over being part of this team. So conservative kidney management can come in two different directions. It can come through shared decision-making, which is on the left. So that's where KRT is available. And we can share decision-making can include transplantation or dialysis, or can go through to a conservative kidney management approach. On the other side, which is where we practice for some of our patients in South Africa and other areas, KRT is not available. We don't have the luxury of transplantation or dialysis for these patients, so they have a choice-restricted pathway to conservative kidney management. It's important to remember that kidney supportive care, conservative kidney management, is not just about managing patients turned down from our kidney replacement programs, which we have now termed choice-restrictive conservative kidney management. It's also about patients on our waiting list. So some of these patients will not actually reach the end point of dialysis. It's also about deciding in a shared decision-making way whether a conservative pathway is more appropriate for a patient. And overall, it's about better management of symptoms for all our patients with kidney failure. So there are times which we're aware where it's appropriate to take a conservative pathway, regardless of resource constraints. For example, patients with advanced dementia, profound hypotension, or a terminal illness with a poor prognosis. Patients who no longer possess decision-making capacity and have stated they do not want dialysis. Patients with irreversible profound neurological impairment. All these patients would be patients that would be inappropriate to take a conservative kidney pathway. So now I'm going to start with my first case scenario, given the little bit of background that I've provided. So you are a primary level care physician, and a 28-year-old woman had a termination of pregnancy for preeclampsia at 6 months gestation with acute kidney injury at discharge. She has a creatinine of about 160 or 1.81 milligrams per deciliter. She fails to attend an outpatient clinic for her follow-up and defaults on all her antihypertensive medication. She's called back to the clinic for counseling and warned about the criteria for acceptance onto kidney replacement therapy, in that it does require adherence to therapy. Unfortunately, and this is one of my patients, she continues to miss her appointments and is not consistent with her medical therapy. She now presents 1 year later with a creatinine of 1,200. She does not meet the strict local criteria for commencing dialysis because she has not been adherent to therapy. So how do you go about caring for her? So it's important that there are local transparent guidelines to decide who is eligible for kidney replacement therapy in centres. And to ensure consistency and fairness, our patient should be formally assessed in the presence of a selection committee to decide on this limited resource. So everything is done very, very fairly. And in a committee that involves other nephrologists, social workers, nurses, the advocate for the patients, and anybody, and also hospital management, which is very important. The superintendent gives the final go-ahead for the patient to enter a program. So unfortunately, our patient is deemed not acceptable to start kidney replacement therapy in the public sector. She's had multiple episodes of non-adherence despite counseling and warning of the dialysis criteria. So these difficult conversations need to be had with this patient. And actually, one of those conversations needs to include the option for private dialysis. And all of this is best dealt with in the setting of a multidisciplinary team. In our setting, that includes a nephrologist, a social worker, a palliative care practitioner, and a palliative care nurse. It's also very important that all these conversations are done with a family member or a significant other to support our patient and be available to assist where necessary. So a family member comes forward to support private dialysis. She needs referral to the private sector. She hasn't got any medical insurance. And in South Africa, there's a 1-year exclusion period for dialysis to be covered by medical insurance. The family will need to pay for vascular access and ongoing dialysis until the medical aid is able to support her. And it is very important that the family understand the significant cost that's associated with this. And what I wanted to point out here was part of the universal health coverage that we can actually bankrupt patient families when they embark on this process. So I'd like to provide a bit more of a global perspective on conservative kidney management. I was involved in the CKM aspect to global kidney health. There was a questionnaire that was developed in 2018 with additional questions that were added in 2022. A distinction was made between conservative kidney management through shared decision-making, which is the blue circle, and then the orange circle is the choice-restricted aspect to CKM. And you can see there's quite a big overlap. And if you look at it in the context of South Africa, that would be the private sector and the public sector and somewhere in between. But interestingly, there is what was noted in this global questionnaire was 39% of countries did not actually have any CKM available at all. What was noted was access to CKM through shared decision-making increases with country income level, 71% in high-income countries, down to 42% in low-income countries. And the reason for choice-restricted CKM was attributed to financial constraints to healthcare systems, financial constraints to patients, and geographical factors. So in South Africa, what I felt very strongly about was this abandonment of patients during this very critical period where they've been turned down for dialysis and basically stuck in a system that's somewhere between the nephrology team turning them down, the physicians who are trying to support them, and often they were left floundering with where and how they're meant to proceed in a healthcare system. So in South Africa, we wanted to take some steps to address the lack of support of our choice-restricted CKM patients, as well as provide better kidney supportive care to all our patients. And importantly, we wanted to assist our healthcare providers in managing these patients. So I was involved in a team, and it was actually heavily supported by Frank Brennan, a palliative care physician in Australia, who actually held our hand during this process. And we embarked on a process to discuss how best to manage patients and their families in this complicated setting. So these are we called them a consensus statement. They're not actually guidelines, but we developed this consensus statement, and we attempted in this statement, which actually gives advice on pain management, on how to deal with symptoms, on how to deal with difficult conversations. But we also attempted to acknowledge the unique cultural, religious, and system barriers that we come up with against in South Africa. The focus was to involve a multidisciplinary team approach to ensure all the symptoms are managed optimally to prevent abandonment during advanced disease. And this was particularly aimed at our choice-restricted CKM patient, but it's actually really can be used for all patients who need a conservative kidney management or renal supportive care assistance. So just importantly, not to forget that implementing choice-restricted CKM requires a comprehensive approach. And at the ground root, This includes the importance of screening for early detection, risk factor modification, and preservation of residual kidney function. When you don't have the end where you can dialyze everybody, it is really important that we try to improve what's going on at the ground roots. It also involves education regarding CKM. And to achieve all of this, there needs to be strengthening at a primary healthcare level, particularly to target high-risk individuals. So I want to emphasize this. If you can't offer at the end, we need to actually pay more attention to the grassroots of the screening, the early detection, and prevention, because CKM is quite high up here, and we really need to focus a lot more down at the bottom of this pyramid. So screening, as many of you or all of you are aware, we need to manage screening and manage CKD appropriately, screening for diabetes and hypertension, urological disorders, family history of kidney disease. In South Africa at the moment, particularly in Cape Town where I practice, there seems to be a pandemic of methamphetamine use, TIC, which we call it here, cocaine, and HIV-positive individuals, and ensure they're virally suppressed, and to avoid tenofovir if they have CKD. It's also important to educate and implement health lifestyle choices to prevent CKD progression, avoid and manage obesity, avoid smoking, salt restriction, optimal management of blood pressure and diabetes, early identification and treatment of those urinary tract infections, and avoid potentially nephrotoxic agents, non-steroidals, over-the-counter medication. And in many of the regions where we practice, we're also dealing with traditional medications that actually can impact on kidney disease, as well as other drugs and illicit drugs. So managing symptoms, as we all know, is extremely important. And the most distressing symptoms for end-stage kidney disease, one is pain, dyspnea, vomiting, anorexia, and terminal restlessness, as well as itchiness. I should have actually put that on as well. And what I learned from the Global Kidney Health Atlas and a reflection about pain management is this access to pain medication is not optimal for all. Non-morphine opioids, for an example, fentanyl, are not available to myself. And when you look at the Global Kidney Health Atlas, they're generally available in 48% of responding countries, but range from 5% in low-income countries. So we, in a low-income resource, low-resource environment, are not able to manage pain for our patients as well as we could, as well as tools to assess pain. And many people aren't aware of these tools, which I'm sure will be touched on in other webinars in the future. And people need to be trained for symptom management, including pain. Also, this was not optimal in the Global Kidney Health Atlas. There's lack of expertise, lack of empowerment of the healthcare providers, and webinars like tonight is all very important for sharing how we manage these patients optimally. I learned a lot from my palliative care team about advanced care planning. It requires knowledge on what and who and when complex conversations should be had. And examples of how to do this we included in our document, and we tried to make it very culturally specific where we could. And advanced care planning is also very interesting. Still in its infancy in many areas, 32% of countries had the infrastructure for advanced care planning and resuscitation directives, and only 24% of those offering choice restricted had any links with advanced care planning or any plan to do it. And when you break it down about why, it does appear that advanced care planning has its roots in Western ethical principles. And when adapting these principles to culturally diverse contexts, there are additional challenges, including limited trust to the healthcare system, acceptance of healthcare symptoms, seeing a different healthcare provider every time they come to the hospital, and discussing topics related to death and dying, which may be regarded as culturally taboo in some settings. So I'm now going to discuss a second case scenario to sort of give an alternative to the other one. I have a 68-year-old diabetic man. He presents with acute on-chronic kidney disease to the emergency unit in a state hospital in South Africa. His current creatinine is 900 or 10.18. His baseline creatinine, however, which has been like this for some time, is 600. And he is requiring a below-knee amputation for an ischemic limb. He has a 5-pack-year smoking history. His blood pressure is 160 over 100, so it could certainly support dialysis. And he's not passing much urine, only 300 mils. He's acidotic with a pH of 7.2 and has a bicarbonate of 18. So the nephrology team here is consulted and they're requesting the possibility of KRT or chronic dialysis. So once again, we've got to go back to our local transparent guidelines to decide who is eligible for chronic dialysis. As you can see, this patient's baseline creatinine is already 600 with an eGFR that's about 8 mils per minute. And so to ensure consistency and fairness, the decision for chronic dialysis, in this case, acute on chronic renal failure, should be aligned with the requirements for the chronic KRT program. So our patient is deemed not acceptable to start KRT. He does not fulfill the criteria for the chronic KRT program. He is not deemed transplantable. He does not have the finances to afford private dialysis. A decision is made to treat the limb conservatively. Difficult conversations need to be had with the patient and his family. And this is best dealt with in the setting of a multidisciplinary team, the nephrologist, the social worker, the palliative care practitioner, and a palliative care nurse if available, and to try and incorporate this into the surgical realm where this patient is currently sitting. It's very important that other family members are included to help support our patient and in an attempt to provide best conservative kidney management. So for me, non-abandonment is very crucial. This patient is likely to have significant symptoms with this ischemic limb, and these need to be assessed and addressed. And very importantly, home-based care needs to be arranged to assist the patient and his family. And this is to provide care for the family, but also to provide the recirculation back into the healthcare services, which is expensive for the service, but also is very inconvenient for the family. So if you can provide the home-based care for this patient in their home setting, it is optimal. An advanced care plan needs to be discussed with a non-resuscitative directive, and rationalization of medication is really important. And the multidisciplinary team support must be continued. So what we've developed, and this wouldn't apply, or may even apply to this patient, we've developed a form that we fill in for our patients who go down this choice restricted conservative kidney management program. We've got a butterfly that identifies these patients in the primary level care system. We've got a nephrological side and we've got a palliative care side. And within our province or within our drainage area, the community healthcare system is becoming more familiar with this. This is still a work in progress, but I feel like we've made a lot of progress. Included on this is for the primary level care physicians and nurses on how to improve symptom support for these patients. So how do we incorporate conservative kidney management if resources are constrained? So for me, although we cannot dialyze all patients, we can advocate that all receive equal and comprehensive palliative and supportive care with non-abandonment during this period. It's really important. And the feedback we get from patients is just incredibly fulfilling that we're not leaving our patients to suffer. And in our nephrology community, we're very surprised that people were worried if we presented this consensus statement or guidelines, that the government would be excused from providing kidney services and transplantation for our patients. So we've had to provide some education to government about how they fit into a kidney care plan. So what we've done a lot to do, and we're still in our early phases, but we've really been doing a lot about education and training. We want to improve community care and prevent admissions back into tertiary level care. This is expensive, as I mentioned before. We want to upskill nephrologists in palliative care, upskill palliative care in end-stage kidney disease for everybody, upskill our primary level care physicians, and we're attempting to do that. Webinars like this are really important. And then also very important for us is to involve families and home-based care, improving communication between tertiary and secondary and primary level care. So just some useful pointers. You can always use high-dose diuretics. Stopping non-essential medication when the time is right is really important. Dyspnea can be very debilitating. Morphine can be very useful, and other pain management strategies are also very important, and I'm sure this will be dealt with in more detail in other webinars. Nausea management. Stop monitoring the kidney function. You don't need to look at it. It only makes the doctor concerned. Ensure patients and families are well informed and supported. Home-based care is put in place, and think about that advanced care plan and the resuscitation directive. So for me, really, end of life, you really must matter until the very end. I want to really thank you for your attention, and I really hope I've got some questions to answer and to interact with you about this really important topic. Thank you very much.
Yes, thank you, Professor Nicola. That was quite an insightful presentation on choice-restricted conservative kidney management. I will just want to open the floor to questions, and I see there's one on the chat box. I think in relation to the first case scenario, one of the attendees by the name of Prosper is asking a question of any reason why the first patient in the first case scenario missed an appointment. Why was she not adhering to medical advice? He thinks that it's probably financial constraints, just asking whether that's right or wrong.
I have to say this is an extremely good question, and what we find is that I actually put this up as an important learning point. Our preeclamptic or maternal discharge and follow-up for patients with hypertension has been very poor. We're actually embarking on a program to actually be involved in trying to at least feed them back into a system for all patients now. But what we did when we analyzed our own center, 17% of our patients on chronic kidney supportive care, kidney replacement therapy were actually missed maternal hypertension. So obviously at another level, there needs to be more emphasis on following up these patients. I do think partly it is financial. I also think there's not enough education. We should be trying to educate patients before they leave hospital about the importance and why it's important for maternal hypertension to be followed up. So that was extremely important point. So thank you for bringing that up.
Thank you for the response. Second question, the chat box from an anonymous attendee saying, excellent talk. Thank you, Professor Nicola. And asking about if you have any comments about a patient with metastatic prostate CA with severe lumbar pain due to the metastasis of the CA. Should we keep 4-hourly sessions twice a week, or palliative care is the only option for such a patient?
So in our setting, we would be, that patient would go down a conservative kidney management approach. We would not continue in our setting that patient on dialysis. We would be doing much more of a palliative care plan. We just don't have the resources to keep them on a chronic plan. So I think that would be not unreasonable. If they've got the option and you could afford it, I mean, it would be a shared decision-making conversation that you can have with the family. Just remember that coming to dialysis is also quite a big chunk out of people's lives that can actually be spending time with their families. So, you know, these are decisions that can be made with the family, but we certainly wouldn't be supporting that patient in our setting.
Thank you for that. Just another question on the chat box from an attendee by the name of Rosak, asking whether you have any experience with children and adolescents on the same.
I do have adolescents in South Africa. You enter the adult service at the age of 13, which is horrific, actually. I have adolescent children of my own, and to think that they are having to be in a public sector adult environment is quite a daunting thing. I personally think it's too young. So I do have a lot of adolescents. We tend to be a little bit more forgiving for an adolescent patient. So I'll just say that they do tend to get a lot of support. We have an excellent transition clinic from our children's hospital. And so we actually do work very closely with our pediatricians. We often get them from pediatrics to adolescents. But these patients need a lot more support. So we actually see them a lot more frequently in the hope that they don't end up losing their graft or, not needing to go down this conservative kidney management pathway. But yes, I have done it. I've done it today for a patient who has tuberous sclerosis, who has neurological impairment and was declined from our program.
Thank you for that response. Another question from Dr. Zipporah Ali, asking for those not able to have CRT in public hospitals, are they able to get private services?
And I did not mention something. I'll mention a little bit about the ethics, because I did see something an ethics question. So anyone can access private healthcare in South Africa, but they have to be able to afford it. And as I said, there's that 1-year exclusion period to getting on to private dialysis is extremely expensive. It can bankrupt families. So I think it's a very tricky scenario to embark on. Saying that, there are some NGOs who assist with the transition period. So there are ways we can actually help patients if they're getting onto a private insurance and they need a bridge. So everybody's able to access it. Now, ethically, there have been quite a number of cases now, quite important cases that have been trialed in South Africa. And the cases have been one supporting the resource limitations of being able to restrict dialysis. So it has been trialed in the court, and they've been found, and the guidelines as such of who is accessing dialysis have been supported. But it's very tricky grounds, and there's always these ethical problems always rear their heads.
Thank you. Question from Alfred, who's asking, how do you go about mitigating the medical legal issues on who to and not to dialyze?
Yeah, I will just, the other important aspect of that is that the guidelines must be very transparent. So, so they are transparent. I didn't put ours up because they do differ from province to province, but they must be transparent. The team must be diligent in ensuring that it is sticking to the rules, so that we are very fair in how we do this. So the fairness is very important. Now I've forgotten what I was going to say, but yeah, so the ethics is difficult. Everything must be transparent and everybody is aware of it. There must be a dedicated team of people who are there at the presentation meeting to ensure that this is a fair process. I see Dr. Bimmer has his hand up there as well.
So what I want to say is, I know I'm speaking from the pediatric side, right? Because that's more emotive. Because if you ask any parent what you want to do for your child, they say anything, you know what I mean? So it's not as straightforward like in adults. But one of the things that, which is present in our setting is that the rule is that we offer all patients one chance at acute dialysis. Now, that's a good thing, and it's a double-edged sword because of the fact that, look, if it's an acute and chronic failure, you might just buy some extra time. You understand what I mean? Right? And which is good. Okay. But I have a problem in that it creates an expectation on the parents that you're going to offer something to this child that's going to make them live longer. Now, they can't afford it, or they don't qualify for the chronic kidney care program, etc. And then when you discuss this conservative kidney care plan with them, they kind of look at you cross-eyed and wonder, now, why is this doctor telling me about this when he already did the dialysis? Why can't we just carry on with that? You know what I mean? So what's your view on that?
Professor Beamer, I also agree with you. We do try not to initiate dialysis where we know that we would rather wait till we've had the meeting before we initiate dialysis. However, as you and everybody knows, there's many crash landers. It's very difficult sometimes to assess that. And I agree with you. I think ultimately we find it easier to not initiate dialysis because once dialysis is started, it's difficult to withdraw. So, and I think children, I just want to put a caveat, children are much more tricky. And I do often phone for my adolescent patients, my pediatric colleagues to try to assist here. But actually just another important aspect with the children and the adolescents is having one child who's actually taking up all the finances for the entire family can actually also hinder the other children in the family. And that's something that I've learned from Professor McCulloch. And so it's a fine line of who you actually accept, but it's, children and adolescents also have a bigger they filter to a bigger family unit. So just to be aware that that's also important.
Yeah, it's what, in ethics we say distributive justice. You know what I mean?
Yeah,
Because it's a
distributive
very
justice.
difficult thing. And why I'm asking the question, many of my colleagues are very unhappy when I say, okay, we're not offering acute dialysis. You know what I mean? Because this child doesn't qualify for the chronic care program. And
Yeah,
you know what, if you just dialyze this child now, he's going to be better, and we can buy
yeah,
one, whatever it is. It's a very emotive thing, you know what I mean?
yeah,
And
100%. I think it's about educating everybody.
Yeah.
Just ensuring you can educate your colleagues about what the different options are. I think that's, and also providing an alternative, which is a conservative kidney management plan, which is a supported plan. I feel like
We are
there's
lucky
been a
now.
lot
We
of
have
buy-in for that. Yeah, for me, I found it's got better.
we got a sort of a palliative care team in place now
Great.
at the Groote,
Yeah.
so that's very helpful for us.
Yeah,
But
it's
thanks.
helped
This
us
is
a
a
lot.
very important topic for those of us from low middle income countries.
Yeah.
Understand of the restrictions on kidney care programs.
Resources.
Thank you for that response, Professor Nicola. Another question from the chat box from Zipporah. Question is on how do you support nutrition in patients in the community? Do they get some education or directions on this?
I'm going to say we are not doing that well. So I think that we could do better. I think it's extremely important. I see there are webinars from this group. I personally feel that we need to upskill on that. So I don't think we're doing as well as we can in the community for nutrition. We do provide leaflets. I think it's inadequate. I think we should be doing better. So yeah, thank you for that really important comment. Hello,
Yes,
Robert. Robert and I have worked
Nicola,
together
and
before.
thank
It's
you,
lovely
team, for
to see
organizing.
you. Thank you.
Is around thank you very much. Now, my question is especially for countries with a nutritionist, we need to have a psychologist, and we need all this. We can hardly have even enough support care department. What would be your guidance around that? Would it be skilling the nephrologists with more?
I think, Robert, you're cutting out a little bit, but I think I got the gist of your question. I feel for myself, and it's something that I feel is very important as well. In every opportunity, we've been giving our pamphlets to our palate every time we're seeing patients, and every time we're in a multidisciplinary team.
I'm really wondering, because we need to do it, but we are already output usually.
I think in all our multidisciplinary teams, everybody needs to be upskilling each other. So we need to also upskill on nutrition. And I think in all our every opportunity we can, we need to try and upskill on nutrition. We're not doing it well. So yeah, Robert, maybe we can come up with something together about how we do that better.
Thank you, Dr. Robert. Thank you, Professor Nicola. Just another question from the chat box from an attendee by the name of Prosper, saying thanks for sharing the experience of South Africa. We face similar concerns in Rwanda. Acute dialysis for AKI is covered by all insurance and social support. Everyone can access it. The challenge is for CKD patients, they have to pay on their out of pocket or be equipped with good insurance. Any advice from you or other attendees on how to make renal care, including renal replacement therapy from any stage like CKD as part of UHC? Yeah, I think it's quite a long one, but yeah.
It is a long one. I think the important thing here, I mean, it seems to me you're also focusing in the private sector. So this is out of pocket, right, from the beginning. I think understanding, the families need to understand the impact, you know, and the universal health coverage is that we shouldn't be decimating our families as well with the expense of this. I think this needs to come through more from all of us about the options that we have. You know, I would love to say that we could offer dialysis to everybody, but unfortunately the reality is that we just don't have the resources to do it. And I personally feel strongly that we shouldn't be breaking families down in trying to manage one patient. So we have to be very careful about how we go about this. For me, it's easy because I'm in the state sector and people don't pay out of pocket. I do try to advise them about what the costs are, and maybe we need to be very upfront from the beginning. This is how much it costs, so that families are aware and it doesn't stop. So I think honest conversations are really important here.
Maybe Dr. Mazza, you can proceed for now.
No, that was by mistake though. But I tend to agree with Prof. Nicci. Before I moved to AHN, I was working in a state hospital, and you would see that, you know, patients would come in and they would have this glimmer of hope that dialysis is going to solve all their problems, which unfortunately is a misinterpretation of the whole system. And I used to kind of, explain to my juniors and my colleagues that we used to work with that you have to be honest at the outset to tell them that, look, you have got a life-threatening illness, and this illness is not going to go away. You're going to stay with it for the rest of your life. And dialysis is not a short-term treatment. It's something that you have to continue to survive. And you have to kind of, you know, say it from the outset, say what the cost is, and they need to then discuss amongst themselves and the families to make these decisions. Because as you say, people have gone bankrupt, and we know people sell their assets and everything, and then they lose the family member. And once they lose a family member, they don't have anything else to live on. So the life completely goes into shambles. And I think this is something that we kind of need to really, really, get it into our counseling, especially, you know, us as nephrologists, because we tend to kind of see these patients, at, say, referral hospitals or wherever we practice. We need to kind of give this information to them so that, they will accept our honesty. I think they will probably appreciate that we are fairly honest with them. But obviously, I mean, at the end of the day, patient has the autonomy to decide for care or against care. And that then we leave it on them. They decide they don't want to do it with us, they want to go to a private facility. Fair enough. But at least you can rest easy to say that you have counseled them on the appropriate nature of their illness. Thank you.
100% agree.
Thank you, Dr. Mazza. I think Dr. Godana is back. Maybe you can unmute and speak, Dr. Godana.
Thank you. Thank you so much for giving me opportunity to say something. Thank you, Nicci, for wonderful talk. I think we had several discussions, and I heard you giving this talk several times, and I always feel, listening it again. And just a kind of few insights from our perspective in Botswana. We are really lucky that government provides holistic renal care to all our patients. So basically, we have access, and everyone in Botswana who is a citizen have access to full renal care, including both types of dialysis and transplant. Transplant, unfortunately, is going very slowly. Up to now, for all these years, we only had 30 patients transplanted in India because of the various logistics issues. It's mainly lack of donors. It's going slowly. But we are now entering the situations because of the lack of guidelines for conservative management, and also us as nephrologists. I mean, I'm sure you're all sharing the same opinion with me. When the patient comes in acute or acute on chronic, you really want to give him benefit of this few dialysis waiting for potassium to settle, waiting for GFR to improve, for urine output to increase. So we are all kind of anxiously waiting for patient to improve, or at least to get to some level that won't need dialysis. And you really want to give him benefit of dialysis. And sometimes we are going over the board. And indeed, it happens that we are dialyzing patients with cancer. We are dialyzing patients with poor compliance. Our patients miss dialysis, but also due to various social economic issues. So the clear guidelines has to be there, and we have to, purely for the protection of government resources, for those ones who are compliant, who have better perspective, to set up some kind of coordinates that we really just don't. I can actually say waste resources, because sometimes that's eventually what happens if we don't have clear guidelines. However, listening to what is happening in other places, we can just say we are blessed because we offer patients vascular accesses. We offer them full palette of necessary treatment free of charge. Even if they're on medical aid, they use their medical aid, and when the medical aid runs out, government steps in. But again, what I want to point is that we have to have a guideline where to stop and where to actually say, no, this cannot go on like this, because otherwise we are now in the situation we're having units outside Wearne. We have poor PD program because patients don't want to go for PD. Another big issue is vena cava superior syndrome, because these patients have multiple vascular accesses and we only have one vascular surgeon. So, if you don't put some stop somewhere, you're going to run into another set of problems. And we are now facing that. So really, that's more of my comment. And thank you again, Nicci, for bringing this very important topic again, so we can discuss among us. Thank you.
Thank you, Gordana. That was excellent. I think one thing I will say is that I don't think that the guidelines are one size fits all for anybody. Our guidelines are specifically for our challenges, and your guidelines will be for your challenges. And I think that's what I am learning, is that that's why I didn't want to put up our guidelines, actually, because they're going to be different for wherever your challenge is. So yeah, thank you very much for your insight there.
Thank you for that. I think Dr. Ntarindwa's hand is up. Dr. Ntarindwa, you can unmute and ask your question.
Yeah, thank you very much, Dr. Nicola, for actually, I can say it is a care kind of unlocking topic that you've just presented to us. And at this stage, I've had some kind of dilemma, wondering whether what I have been doing has been right. I'm from Rwanda. There is a dialysis unit I supervise at the border with DRC. And we get patients across from Goma, from Congo. I happen to I have a patient with advanced carcinoma of the prostate. And now, having had my training in South Africa, in Johannesburg, usually such cases actually are not taken up on public account, like you have already highlighted. But the family was actually it's a private dialysis facility, and the family was ready to pay for the dialysis. So I had a long chat with the family about the outcomes, what they expect, so that I highlight to them really what my limitations are. And at the end of the day, we agreed that we are going to continue with the dialysis, but they knew the cost implications, and they knew that dialysis won't bring about a cure. It will just prolong life. Now, finally what we agreed is this patient now is on morphine cocktail to relieve pain, and he comes for dialysis, I think. If I remember I think I advised him to dialyze twice instead of three times a week. And then I advised them not to, and I told even the doctor there who is supervising on a daily basis, not to do monthly tests, because they're less expensive, and probably if you do them regularly, whatever, the outcome on that really is not worth, worth the cost. So I'm just saying you this to tell me whether what I'm doing is actually the right thing for this patient.
Joseph, I think the important thing is here that you're practicing shared decision making. The decision needs, if you've got resources, the decision needs to be made with the family. They need to be aware of all the options. I think this is a very critical, and everybody needs to understand the patient, their family, what the pros and cons are, and to have a shared decision making approach. So there's no right or wrong answer. And if this patient still has a quality of life, despite the mismorphine, and however, they're still having quality of life and they feel that they want to continue dialysis, then it's the right decision.
Yeah, what I wasn't very sure is it worth really subjecting the family to monthly laboratory tests?
Well, I personally think not. So, but also if you've made a decision, maybe your decision is that you cut back on that and you're just offering palliative dialysis in a way. So, okay. Particularly, I don't think there's anything wrong with that. I think you can actually have that discussion with them that you might not be able to optimally manage dialysis, but you're going to manage it because the cost is very expensive, right, for the whole family. I personally think that would be a shared decision-making exercise with the family.
Thank you, Professor Nicola. I think we have 2 more questions on the Q&A. I hope you are okay for time.
I'm good, thanks.
All right, so first question is from an anonymous attendee asking, in case of public hospitals doesn't provide kidney replacement therapy and private hospitals are out of pocket that patients can't afford, what is the best conservative plan for such patients, and which symptoms and signs should he seriously worry about and consider to control?
So I'm just going to talk very briefly through a patient that would happen to with us weekly. So we would have a patient that is turned down. We would meet with the nephrologist, the palliative care physician. We would, the family, the social worker, we'd ensure a grant is put in place. Some patients can live with creatinines of 500 for some period and have no symptoms. Some patients have a lot of symptoms. So I think the bottom line is that you really need to sit with everybody, individualize the treatment, have yourself a strategy of what you do for pain, what you do for itching, what you do, and ensure that the team are aware of how to manage this and that there is primary level care support for this patient. So I'm in a tertiary service that we now refer down to a palliative care service in a primary level care. And that's what they're the connections we're trying to build without, like we being the tertiary level hub and trying to build out into the primary level care. So I feel that if the private option isn't available, you set up something which for us very importantly is money, a grant to assist the family or the carer, and to ensure home-based care is put in place and that there is support for the family and the community. And we actually take them away from a tertiary facility, which is trying to focus on a different aspects of renal care. So that is the very short answer to a very short response to what is a long answer. Should be a long one. Yeah, individualize it per patient.
Thank you for that response. I think last question on the chat box is on what is the age limit for dialysis in your patients? I think maybe this is in the context of sometimes you get very old patients. I'm hoping that's what the attendee is trying to ask. Maybe the patient is around 90s or...
yes. No. So I don't agree with at the moment, I don't actually quite agree with what we've got on our guidelines, which is one reason why I haven't displayed them. But there is an age cutoff for our patients, and it's 60. And I don't think every 60 is the same. So I do think that's why we make it transplantability. But in our state sector, we have a cutoff of 60. But there are good 60s and there are not good 60s. So, but we certainly don't go above 60. Whether we should go as low as 60, I think could be debated. But yeah, there is cutoff. And as I sort of tried to stress in our center, transplantability is what is our core fundamental acceptance onto a program for medical and social reasons.
Thank you for that. Just a comment from one of our nurses by the name of Yusafia, who says perhaps we need psychologists in the dialysis centers.
Agreed.
Or get to train some personnel. There's a huge gap on this.
Yeah, agreed. And I must say our social workers really do a fine job at trying to fill a very big gap. And also we're just in the process of employing a youth worker as well. So, I think we've got to think more laterally when resources are constrained of how we task shift to get out into the community.
So thank you for that response. Yeah.
Sorry.
So thank you again, Professor Nicola, for making time. And we had quite an interesting and insightful presentation. Looking forward to having you more and more in future. We learn from your wealth of experience. And on behalf of the panelists at Africa Healthcare Network and our sponsors, I'll want to convey my thanks, and I would like to hand it over to Dr. Lloyd for some closing remarks. Thank you.
Thank you very much. Thank you very much. This is a wonderful section, and actually highlighted very, very important aspects on conservative kidney management in a choice situation, and especially the practical situation that we face. And I guess although there may be some changes, there are some at least local guidelines which may be common, which can be taken from there. And we are very grateful to you for having come on today and actually leading some changes that we hope to bring about in East Africa and carry it along into the whole team. And we hope that you will come and join us again and guide us along the way. Thank you very much.
Thank you. Such a pleasure. I really enjoyed being here, and I actually really enjoyed the conversations. I think the conversations are really important, and hearing people's experiences and sharing them. So thank you for sharing them with me as well.
Thank you so much.
Apologies, Professor Nicola. I think I don't want to close out as an attendee by the name Sarah Njoki. I think was a comment.
Yes, thank you very much, Daktari. Now, I'm just thinking about that 6 years cutoff. I think in our country, I'm talking of Kenya, you will not believe it. We support even such old people, like even in their 70s, you see them, you dialyze even for 10 years. And okay, with some quality of life. I think our program is covered by the government, apart from the 2 months. And you see now there is encouragement in the country where like everybody, it is like everybody has an NHIF. And if they don't have, they just have 2 months to do the cash. And then we go on dialysis. And like I can give you an example of an 80-year-old who has been on dialysis for 5 years. And as I think maybe as Africans or as Kenyans, there's a way we pool resources, because now if the government is covering the dialysis, the other costs of food and transport, most Kenyans actually, even a whole village will support that.
Yeah.
So your program, when you talk of 60 years, and when you talk of patients who are not transplantable, like a lot of people are not transplantable because of finances. But you see, we support them. We supported patients even for 20 years. Even me, myself, right now, I'm like almost 60. If I have a lease of 20 years, I'll definitely add value to the society. I don't know what you mean when you say that it is expensive. Okay, it is, but imagine we have a way. We support our patients, and most of our dialysis patients, actually, we will go on. And I don't know how it happens, but you realize some of these old people, like I can give you an example of my neighbor. We dialyzed for 3 years, and then they opened up, and I can say he added a lot of value to the family. So your program, to me, as a Kenyan, I think it is awfully short-sighted and mean to the old people. And I think this is a sort of a discrimination in a way. Because
I agree, Sarah, I do agree with you. You know, that's what I said. I don't enjoy the age cutoff, but I'm just saying we only have 160 slots in our unit. So that is the rule. And the only way we can turn the slots over is to transplant them. I don't say that I agree with it. And I think it's important, your comment. And I personally think that we do cut it off too early. And I do agree with you, it is mean. So, but I think these are the decisions when you've got resources and decisions you need to make. They're very difficult ones. And I actually acknowledge your difficulty with that, because I certainly have the same.
Thank you, Professor Nicola. Yes, I think just highlighting some of the challenges and the different dynamics to it, But again, I want to just convey my thanks for making time. And on behalf of African Healthcare Network, I want to say thank you and looking forward to having more sessions.
Thank you very much. Have a lovely evening, everybody.
Good evening to you too.
You too.
Thank you.
Bye.
Thank you so much.